Hello, everyone, and welcome to the Babies in Common Show. I'm Jeanette.
And I'm Melissa. Welcome, listeners. Please note that any information shared during the show is not to be taken as medical advice. Please consult your own care providers for questions about you or your baby's health and visit babiesincommon.com/disclaimer to read more.
All right. So today is Wednesday, February 24th, 2021. And our guest today is Dr. Kelly Bowen, who is here with us today for an Ask the OBGYN Gynecology edition. I'm very excited for this episode because we obviously have covered a lot of obstetrical, pregnancy, birth topics, but we haven't had any gynecology focused episodes yet.
Yes, I am also excited for today because our guest is a former labor and delivery colleague and dear friend of mine, Dr. Kelly Bowen. Originally from Connecticut, Dr. Bowen moved to the Midwest to attend Des Moines University College of Osteopathic Medicine for medical school and headed back to the East Coast to complete her OBGYN residency at Jersey Shore University Medical Center in Neptune City, New Jersey. And let me tell you, her stories from that facility are intense. And what's so funny is I remember, Kelly, when you first told me that you went, I was like, oh, where'd you do residency here? Like Jersey Shore University Medical Center. I thought you were like, I didn't know that was a real place.
That's exactly what happened when I was applying. I was like, that's real? LOL. And
I
applied.
thought you were making a joke, you know?
So did I until I matched there.
So, I mean, JSUMC, it's a regional perinatal center, which means that it has a level 3 NICU, and they can take care of the highest risk maternity patients and babies in that region of New Jersey. So, I mean, certainly a thorough residency program, which is great for your education. But as someone who also worked in a regional perinatal center as the start of my nursing career, we could probably match some stories for sure, because it is quite an education. But now you're back in New England. And when you're not catching babies or performing gynecological surgery at a community hospital in Massachusetts, you can probably find her knitting, felting, or crocheting boob hats for her friends' babies, or documenting the crazy antics of her adorable cat named Sushi. So welcome, Kelly.
Thank you. I'm so excited to be here.
Awesome. So I love that you are a DO, a doctor of osteopathy. So instead of an MD, medical doctor, but many people don't realize there are different types of medical schools and they don't understand what a DO is and what maybe some of the benefits to that approach of medicine would be. So can you explain what it is, why you chose that, what they do differently or the same, all those things?
Absolutely. So DO stands for Doctorate of Osteopathy. There's two major strains of medical training in the United States. One is Doctorate of Osteopathy, and the other one is Doctorate of Medicine, which is MD. We call that, to the osteopathic community, we call that allopathic medicine. So when I was in my training, I went through everything that the allopathic MD programs go through, but we have additional training. And it's also a difference in fundamental philosophy to a certain degree. That window is changing as the MD schools continue to seek more training for their students in complementary and alternative medicines. But in osteopathy, our fundamental philosophy is based on how form and structure are integral to one another. And so we do additional training that the MD students do not do, and some modalities that you might find in the complementary and alternative medicines, like acupressure points, a lot of chiropractic techniques overlap, some massage therapy techniques overlap. The idea is that if you have a well form, that you can have a well function. And while certainly certain things require the use of medicines or surgeries, that having the form of the body be in good shape, in good condition, will facilitate healing in a faster way. And that some, especially musculoskeletal conditions, are best treated physically with kind of body work sort of techniques rather than using drugs or surgeries. So we kind of have a built-in holistic view, and that's kind of our starting philosophy, and we're tested on that from start to finish.
That's amazing. So do
That
you
is
actually do manipulations, as they're called, on your pregnant parents?
I have done some. I also will teach them, some of the patients, how to do things themselves, or to have their partners help them with some of these. And I find that it leads itself very easily into techniques like spinning babies, or the positionings that we do for our patients in labor. I found that very intuitive, and so that stuff really appeals to me. I also found that my palpatory skills are better than some of my colleagues, which means that I am more adept sometimes at rotating fetal heads, or knowing the position of a baby than some of my colleagues. But that, of course, is very provider dependent, and it completely depends on how much time an individual person is willing to put into it, and how much they feel that it will help their patients.
Right. That's so true. But that's true about patients too. You
I
know, as a spinning babies
right.
parent educator, you know,
Mm-hmm.
I love that you love spinning babies. And so when I teach that with parents, it really depends on how committed they are doing the moves too, and remembering like to
Absolutely.
do them in pregnancy. And the earlier they take that class, the more they can do that every day, or some positions throughout the week. And then
Mm-hmm.
in labor too. And it makes so much sense. But then you add in, you know, what you do or all the other physical complementary things. I think it's amazing that you get to do that all together.
I think it helps.
Absolutely. See, listeners,
I
it
think
does.
it's
It
such an
helps.
awesome well, it's I like to think of it as a toolbox, right?
Mm-hmm.
So every type of practitioner, whether you're an allopathic, practitioner, you are a chiropractor, you are a DO, you are a nurse, you are a midwife, you have a different toolbox of
Mm-hmm.
tools. And so you might look at a quote problem in, let's say, labor differently. And so if your toolbox, when you look down in it, based on your training, your education, your experience, your mentorship, is only forceps and
Mm-hmm.
vacuums, right?
Mm-hmm.
Then it's not that you're a bad
Mm-hmm.
person. It's just that that's the only tool that you were
Right.
taught. And, if you're a DO or a midwife or a nurse, like I've been incorporating spinning babies with my labor and delivery clients for the past 10 years, I'm going to see a dysfunctional labor and I'm going to say, what can we do to make more space for
Mm-hmm.
the baby? And what's funny is, even before I started working with you, Kelly, which we clicked instantly, because as you can already tell, listeners, we have a lot in common. But I've had doctors say to me, well, I don't, they come to break a patient's water and I say, oh, can you give me like 20 minutes just so I can like do some spinning babies moves? And they look right at me and say, I don't believe in spinning babies. And I always kind of like have to like bite my tongue and be like, it's not like religion. Like it's not something that you either believe in or not. Like the reality is our form affects our function, and our bodies are very smart. And sometimes if we can facilitate our bodies doing what they can be capable of doing many times by just releasing, tension and facilitating space, that can lead to movement and progression. And I had a lot of non-believers. I had a lot of non-believers in my 14 years as a labor and delivery nurse, that then that patient that is heading to the OR all of a sudden is crowning. And it's nice. It's a good feeling to have, some tools in your toolbox that can make a difference like that. Not to say that they always work.
Right.
I mean, Kelly, one thing that's I know about you personally working with you is you also do a really incredible cesarean.
Aww.
And I think that understanding how the body works, right? And you said your palpation skills are very good. Like that actually also lends itself to your surgical expertise. And so that's important too, because sometimes we do need surgery. We do, just because we're doing surgery doesn't mean it's easy to get a baby out. Sometimes it is quite difficult still, the babies,
So Melissa, you just said she does a really great cesarean. So from a nurse's perspective, having observed many cesareans in your career, what do you mean by that? I'm sure people are listening going, isn't a cesarean? And all the surgeons are taught how to do it, and it's pretty straightforward. So can you explain a little bit more about what that means? Like the differences you've seen between providers?
Well, Kelly could probably talk about this better than me because she's actually a surgeon. I just scrubbed in and assisted. But I mean, the reality is that surgery is a skill that you need to use your hands for. And so anything you use your hands for, like Kelly knows how to crochet and felt and knit beautiful.
Ooh, that's a good point.
Clothing.
Right.
Some people really want to be a surgeon, in
Mhm.
medical school and don't have the
Yeah.
dexterity to
Mm.
perform the types of moves that you need. Even, suturing vaginal tears. There are some doctors and some midwives that do an incredibly
Yeah.
amazing job because they not only understand the form and function in a really deep level, but they also have the dexterity to do that type of movement with their body. I mean, getting a baby out by cesarean is physical. Doing a
Mm.
vacuum and forceps is a
Mhm.
physical thing. You will strain sometimes too, and knowing how to move the baby so that you're not putting too much strain and pressure on the baby, knowing where to place the incision, how big to
Mhm.
make it, not too big, not too small, to give you the space you need. How when they reach in to
Mm.
get the baby, they don't see where the
Mhm.
baby is. They're feeling with their hands. They're feeling on the outside of the uterus. They're feeling on the inside. They're having someone, and they're guiding their assistant, pushing at the top, how hard, when to start and stop. And so that takes a lot of muscle intelligence and a lot of dexterity like that. So I'm not surprised hearing more about your training,
Mhm.
Kelly. Why you're so good at what you
Oh,
do,
thanks.
because I've
Mm.
seen you in
Mhm.
action. Oh, I know. I'm just a big fan.
Although I
I
will
mean,
say, as far as vaginal tears go, I am a really big fan of the AWAN study that showed that putting a hot compress on the perineum will reduce the rate of tears. I don't like to stand there and repair the tears. I don't like it. I'd
Mm.
much rather hold a hot compress to the perineum and not get a tear.
mhm. I'm always telling partners,
I
you don't need a medical degree to hold a warm cloth to someone's perineum.
No, I'm actually trying to get it standard at Milford Hospital, and I think that that's
Oh,
coming
good,
very soon because it's
good.
a super, super easy intervention,
Right.
that a lot of our nurses, now that I've been doing it, there consistently for a year, they're seeing the
Mhm.
outcomes anecdotally themselves, even though they could just read the study. But I think that the two together, the study plus the anecdote,
Well,
has
midwives
helped
have been
them.
doing that for decades, if not centuries, right?
Absolutely, yes. And some of our older nurses said, well, that used to be a thing that we did
Mm,
standard anyway. And I'm like, great, let's bring it back. It's
right.
not a
Right.
difficult thing to do.
Well, you had me at knitting because I mean,
Absolutely.
just the idea that you have the talent to do that. I grew up, my mother's she does tatting and makes lace and she's very
Hmm.
talented. And just the intricacy there, that makes sense that that would lend you to surgical skills. Not to say that every surgeon needs to do handiwork, but it just makes sense.
Or that everybody can sew your vagina. I'm not
Yeah.
saying
Right.
you should. But I digress.
Yes,
So let's
yes.
go to our listener questions.
Hmm.
One of our first listener questions is, I gave birth to my first baby 6 months ago. I'm anxious to get pregnant
Hmm.
again as soon as possible because it took us a couple years to get pregnant the first time. How long should I wait before trying to get pregnant again? And I will add a little question to that question is, does your recommendation about pregnancy spacing change if that person has had a cesarean birth?
Great question. I get asked this question at almost every single postpartum visit. It's rare that a patient already knows the answer to this, truthfully. Um, so ACOG, which stands for the American College of Obstetrician and Gynecologists, they put out a guideline that's also been endorsed by the American College of Nurse Midwives and the National Association of Nurse Practitioners who are practicing in women's health. So that means that we have basically all the OB/GYN providers that you're realistically going to have for the most part covered with this recommendation. They feel that getting pregnant within 6 months of your delivery is very hazardous. We know that patients who get pregnant again in this time frame face a much higher risk, especially of preterm birth, of added rates of preeclampsia, of diabetes. Many women don't have the opportunity to lose the weight that they may have gained during their pregnancy. So that's the major risk, is the greatest risk, I should say, is to patients who get pregnant again in that short time frame. That doesn't mean that everyone who conceives, I guess, quote unquote, by accident, as my patients might say, in that time frame are doomed to have this happen. If you get pregnant in that time frame, you should not despair. You should be in contact with your provider, because for the most part, the short interval pregnancy patients that I've seen have done okay, but we don't want to plan for that. As far as the interval in the 18-month range, that's the standard guideline that we give, is that we want most patients to get pregnant approximately 18 months after their delivery. That data is probably needs a little touching up, because for the patients who are low risk, who had a spontaneous vaginal delivery, who are healthy, who didn't have diabetes, who did not have an excessive weight gain, who are able to lose the weight relatively quickly, who are not advanced maternal age, all of that kind of stuff, and especially didn't have a big laceration or a surgery, those patients will probably do okay. So they're trying to nail down a guideline for a date, and it kind of depends on who you ask. But there's two special populations that we want to make mention of, and one of those is the advanced maternal age patients, so patients 35 years and above. The guidelines still stand that they do want you to wait, because you're at increased risk because of your age of having preeclampsia and diabetes and the other things, even if you had a normal vaginal delivery and an uncomplicated pregnancy, still advisable to wait. And those patients who struggle with infertility and need artificial reproductive technologies like IVF, they're supposed to be waiting about a year. There was a big study done by the infertility specialists to try to nail that down, because of course those patients are afraid that they won't be able to have another baby, just like the patient who asked this question. So the short answer for most of it is you should wait. But please, please, please make your concerns known to your provider that you struggled to become pregnant over several years. There's a lot available out there to try to help you treat, and there's some people who really don't want medical intervention as far as taking medications to help them get pregnant, which is understandable. But it doesn't hurt to have your provider in on your fears, so that they can help you come up with a game plan of deadlines for when would you start evaluating things, when would you want to do medicines, when do you want intervention for you as a family. And then to the second part of the question, as far as cesarean goes, it kind of depends. You're still advised to wait approximately the same amount of time, but if you're a patient who had a cesarean and you would really like to pursue TOLAC, which stands for trial of labor after cesarean, if you'd like to have a vaginal birth after your cesarean, it's very advisable to wait above 18 months, because patients who had cesarean within 18 months of their new pregnancy are much greater risk of failing a TOLAC. And if they get pregnant very soon afterwards, within 6 months, the rates of the placenta adhering to the wall of the uterus or inserting itself over your cervix are much, much higher. Those patients are at, I think, 6 times greater risk of needing a blood transfusion at their next delivery. So it's not the end of the world if you do become pregnant, quote unquote, by accident in that short interval. But it's best to try to wait and then just get yourself all teed up for your next baby.
I heard something fun recently. A client of mine, we were talking about the future, and she said, well, I'm going to wait till I finish having everyone first.
Having everyone first.
I was like, oh my gosh, I love that.
Can I tell you what one of my patients told me today? She told me, I'm going to fix my body completely before I go ahead and destroy it again.
Oh.
Well, all in good fun. I love that she said that, because it's like, I always joke, like the kids, they suck the life out of you when you're pregnant, and then they continue to suck the life out of you once they're not pregnant anymore. Yeah. But I say that in jest. I mean, obviously I'm not, I'm being silly, but
someday they're old enough to give you massages, though. So it does come back around.
Oh, good for you.
I hear that they start giving, I mean, my kids, honest to God, my 8-year-old and my 4.5-year-old today chopped ice in my driveway, probably 200 feet worth of ice in my driveway today, because I made it seem really, really fun to do. And of course, then they fought over it and actually did it. So yeah, at some point they do stop, they still,
can I recruit your child? Because I did that for myself in my driveway, and I managed 3 feet before I was like, and let's take a break.
Exactly.
We earned some iced coffee.
But on a more serious note, I do think it's important. I hear this a lot, especially, even I hear it from younger people that like don't have a history of infertility, that just want to get pregnant again right away. They have this idea that they want to space their pregnancies really close. They want their kids to be close. As someone who's been working with new families for 14 years, as someone who's the oldest of 7 kids and 21 grandkids, right? I have to say that spacing doesn't necessarily mean your kids are going to be the best of friends. If they're close together, if they're far apart. Like I said, there's 7 of us. And so, I have close relationships with some of my siblings, and some of my siblings we don't, just because of our personalities and what we're into. One of my closest relationships is with my youngest brother, who's 14 years younger than me. And so, sometimes we panic. I know because I can speak from experience. I was diagnosed with infertility when I was 27. It took me 3 years to get pregnant with my son. And so I already felt like I was behind. I felt like everybody was having babies and I wasn't, and I was behind. And that wasn't true. You're always going to find mom friends no matter what age you are. And motherhood or parenthood is really the universal equalizer. It doesn't matter if you're 45 years old with a PhD from MIT, or you're a 18-year-old new college grad. I mean, a new high school grad. Parenting's going to bring you to your knees. You're gonna have things in common with people, and with kids, it takes 9 months to grow a baby. My grandmother even said this on her podcast. It takes 9 months to grow a baby. It takes at least 9 months for things to kind of figure their way back together. And, just to nourish your body, mind, and soul, your mental health, your relationship with that baby before embarking on another pregnancy, which people don't realize until it happens, but is not going to be the same as your first. You are now not able to nap whenever you want, and can't just come home from work and go to sleep. And you are parenting a toddler or preschooler, sometimes, and also being pregnant with all of that. So just kind of keep that in mind, that sometimes it feels like there's a rush in our culture, but there are moms, especially where we are in Massachusetts, having babies. I'm not saying purposefully wait till you're at the end of the game, but just don't think that all hope is lost if you don't have your kids bang 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 bang.
Yeah, well, there's actually data also to say, while we're talking about waiting a long time, moms that wait, it's a wide range. They said 5 to 10 years in the retrospective study, but there's things in complications from, quote, waiting too long as well. But that statistics mean nothing to the individual person, and we shouldn't take our cues to hurry up and get pregnant, or to slow down and not get pregnant again based purely on statistics. You should take, obviously, your life comes first.
Yeah, totally. So on the flip side of trying to get pregnant, let's talk about not trying to get pregnant, contraception. Since adequate pregnancy spacing, is a factor in healthy birth outcomes, contraception is important. And yet still too many people believe that you can't get pregnant when you're breastfeeding, which is false. It is false. It is
I've known people at 4 weeks postpartum, like, I swear I'm breastfeeding around the clock, multiple times, even at night. And I'm like, I know the research shows that won't happen, but it does.
And you're going
only
to
1 in 4 women are going to get only 1 in 4 women will have what's called LAM, which is lactational amenorrhea, which means like complete ovarian that you can't rely on.
Right. You can't rely on that, because you are going to pop your egg 2 weeks before you have your first period. And that is when, spoiler alert, you are the most aroused. And so even if you don't want to touch your husband at all because you're tired and you're leaking milk and you're exhausted and you don't ever, there's going to be that one, all it takes is one night where you finally are like, damn, boy, where you been all my life? And then all of a sudden, bam, you're pregnant. You're like, but I didn't even get my period. It can happen. So the good news is, here's the good news though, there are many hormonal and non-hormonal contraceptive options available for breastfeeding parents. We don't have time to go into all of them. One great example though that I want to talk about today is the IUD, the intrauterine device. Can you explain a little bit about what that is, how it is inserted, and why it's such a great option for a busy parent?
I love IUDs. They do so much. So they really hit the sweet spot for an enormous number of patients. So an IUD, intrauterine device, in the United States currently. They are all T-shaped devices. So it's like a little line with a little crossbar that goes on top of it. They are all inserted, almost all inserted through the cervix. There are some kinds that are available to patients in certain circumstances where they can actually get them placed at the time of their cesarean. The doctor just drops it into the uterus and sews your uterus shut. But that's
Wow.
the most common, is when patients will come into the doctor or other provider's office and it will be placed through the cervix with a speculum in. It takes, for me, when I do them, it takes less than 5 minutes, typically. And they, as soon as it's set into the uterus, you have instant contraception. The Paragard, which is the version that does not have hormone in it, is approved for emergency contraception. So even if you had a little oops, like Melissa's saying, and you wake up the next day and go, oh my goodness, my logic fell out the window, and you speak with your provider, they can sometimes get you in and provide you with that emergency contraception of the Paragard.
Wow.
There's 2 major branches of the IUDs. There's flavors with hormone, and then there's the flavors that have no hormone. In the US, the only non-hormone flavor is the copper-based IUD, which is called Paragard. Most of my patients prefer the hormone-containing one because it has the added perk of giving you a decrease in your period for most women. For many, many, many of my patients, over time, their period will go completely away. Which is usually very appealing to all women, but especially to busy moms who have ain't got time for that. So it's a set it and forget it kind of thing. It's always with you. It's portable. Right now, the Mirena, which is the most popular of the hormone-containing varieties of IUD, is approved for up to 5 years for contraception. They're at the cusp, I believe, of being approved for 6 to 7 years for contraception. It has additional benefits for my patients with PCOS. It can help them to prevent, who don't want to be pregnant, of course. It can help to prevent overgrowth of the uterine lining, which for them comes out as like these really horrible periods that are very long, very bloody, and occur every 3 to 4 months. So it has dual purpose for a lot of people. And the Mirena is approved to treat people with uterine hyperplasia, which means overgrowth of the uterine lining, which is a precursor to uterine cancer. So it's also used in women in their 40s, heading toward 50, even above 50, who are at risk of getting uterus cancer, to sort of just place it into the uterus and let it do its magic. The hormone-containing IUDs work by exuding a small quantity of progesterone that is locally effective. So it works on the uterine lining without having effects on a greater level to the ovaries. So for the most part, the ovaries are not suppressed, which means that your ovaries are still cycling in the background. Many patients will still have breast tenderness or other side effects that they would have for PMS, to let them know that their ovaries still function, which is a perk for those patients who don't like systemic hormone, or who don't want to go through all that trouble of on-ramping onto pills, suppressing their ovaries, and then coming back off of them again and waiting a couple of months while it washes out of their system to become pregnant again. So for many women, it works really well to time their pregnancies, because you have it placed and then you remove it and then they become pregnant shortly thereafter. So it's got a lot of great benefits to it. And it's thankfully slowly becoming more popular.
Right. One thing that you didn't mention was that the copper IUD you can keep in for 10 to 12 years.
That's correct. Absolutely right. And so I do have a few patients. I mentioned, of course, that the Mirena is a little bit more popular because most women, when they get the choice, would love to have absolutely no periods at all, especially for a prolonged period. But there are some patients for whom hormone of any kind is not acceptable. I do have a very young patient who was diagnosed with very early breast cancer. Thankfully, she's doing very well, but for her and her partner, conception, for at least now, is not an option, and she really cannot be exposed to any hormone, no matter how little, based on her oncologist recommendations. And so she and her partner use the Paragard, and the upside for her is to have had it placed once. and to be able to go through all the rest of her treatment and just come to see me for annual exams, and I check to make sure that it's in the right position, and otherwise she's good to go for that long of a time frame without having to do anything else.
So if the IUD has so many benefits, and I'll share my
Mhm.
experience in a minute, because in the interest of full disclosure, I also love my Mirena, but I don't get
And
paid by that company.
I love my Paragard, and I actually
Oh,
I have my second Paragard, so I'm gonna have it for about 22 to 24 years.
Wow.
very
All
nice.
right.
I'm
Total.
planning
So-
to get a Mirena myself because, as you can see, I'm a little fluffier.
More to love, Kelly.
More to love, more squishiness. But I am a patient who's at an increased risk of eventually getting uterus cancer. My cycles are regular right now, which is TMI, but at one point I will probably go ahead and get it to just suppress that uterine lining so that I can bring my chance of uterus cancer all the way down.
Excellent. Yeah, no, there's so many benefits. And yet I worked in OBGYN office for 4 years. Part of my job was counseling about different contraceptive options. And there's a lot of myths out there about IUDs. So can you talk just a little bit about the history of why IUDs get such a bad rap and bust some myths for us?
So there's actually a really, really great podcast episode, especially if you're someone like me who kind of likes not conspiracy theories, but someone who's kind of a socialist and really doesn't believe in like big business and big companies and all of that. There's a podcast called Swindled out there, and they have an episode specifically about how greed ended up harming many, many, many women in this 1970s, and that's what it boils down to. So the IUDs were, I believe that somebody in Syracuse, I think, someone in upstate New York, a doctor in upstate New York, came out with this concept of the IUD, which is essentially any item placed in the uterus can create a hostile environment to sperm and to implantation, and so it can prevent pregnancy. We learned this from nomadic tribes in the Middle East who used to place rocks in the uteri, I guess, of their camels after they had given birth to prevent them from becoming pregnant again during like very long journeys, I believe.
Oh my gosh, what was that conversation? Shall we put a rock in there? What do you think?
I wonder.
You put the rock in. No, you put the rock in.
How big should the rock be?
Or who first thought, like, you know what sounds like a good idea? Putting a rock in my animal that I depend on to get across the desert. Sounds great. That can't possibly cause a problem. That's a simplified version of what I was in medical school. I don't officially know. But in any case, a doctor in upstate New York came up with this idea in, I believe, the 1950s or early 60s. And the early models were ones that he had made. One was called the Lippy's Loop, which Dr. Deloche will be very proud of me for knowing what it was called. But in any case, this sort of became a booming business because, of course, everybody knows the history of the pill and that it was heavily stigmatized. And as the 60s grew into the 70s, more and more the demand for alternative contraceptive methods that were not hormonal grew. And so there was productions of certain kinds of IUDs. There was two major issues. Some were made with a very odd shape, like the Dalcon shield, which I believe had a lot of pointy bits on the side. I'm not 100% sure why they thought that would be better. It wasn't better. And in fact, caused more discomfort. It put patients at a much greater risk of scarring or perforation of the uterus. And the other kinds, some of the other kinds of IUDs were manufactured with inappropriate string material, which is the sort of material that we use to remove the IUD. It has these little tassels on it. They were made out of braided material, which of course makes it very easy for bacteria to get into the uterus, and they were not sealed on the ends. And this was done to cut corners, to increase profit margins, which is not acceptable. And of course, so many of the patients at the time who were getting IUDs were persons of color, disadvantaged women who already had children, possibly out of wedlock, or were just young women in general. And as we know, in the history of women's health, women are typically ignored by especially their male physicians at the time. And so there was a lot of downplaying of women's symptoms, and for some women, by the time that the real issue was found out, and that these women had infections, some died, and some were faced with permanent irreparable harm. So understandably, after that got out, there was a lot of people who were not trusting of IUDs and not trusting of doctors, which is appropriate for the times.
So, I mean, obviously that's a horrifying history, and that's not the only drug or medical device that has a horrifying history. I mean, we can come up with, you know, DES and thalidomide and, you know, things where there wasn't a proper studies going on. People who with symptoms were ignored. There wasn't any way for them to sound the alarm, and, you know, so that did happen. That is true. However, you know, the IUDs that are on the market today, you know, have hundreds of thousands of patients that have been studied for safety and efficacy. We've had them on the market for many years, and they aren't for everybody. You can have side effects. There are downsides to all types of contraception, you know, even something like a condom, right? Which is cheap. That's a pro, right? There's no hormones involved. It protects against sexually transmitted infections. But if you're in like a monogamous relationship, like using a condom can be kind of a bummer, and also, you know, rarely, but could break, for example. So no contraceptive option is 100% perfect. People can have hormonal side effects. You know, a copper T, Paragard IUDs can make your periods maybe even heavier and more crampy without the hormones. But remember that people focus on the negative. Like when you know, if you go on Facebook, and I see this a lot, people are like, you know, I'm thinking about getting an IUD. What should I do? It's like 1,000 hits of, well, my best friend's sister's girlfriend's mother had an IUD that perfed her uterus. And it's like, those things can happen. And there are risk factors that can increase your chances of having pelvic inflammatory disease or a perforation of the uterus. But I worked for OBGYN office for 4 years, where one of our satellite offices was at Harvard University. And we had primarily not just students, but mostly young students who wanted to not get pregnant before they graduated college. And we would do dozens and dozens of IUDs a day, right? And I fielded all of the phone calls with my 2 other nurse colleagues. We shared a phone bank. I fielded all of the phone calls from that satellite site for 4 years when people would call with concerns about anything gynecology related. And those concerns about their IUD were rare. If they were present, they were minor, like, oh, you know, I'm getting more acne with my IUD, or my periods are heavy with my IUD. Not to say that that might not be a deal breaker for you. It might, right? But rarely was it a serious complication. Not that it's not impossible. So I just want to encourage people to, like, don't let fear mongering affect your ability to make an educated, informed choice with your provider about the best option for you. Because I know personally, I've had both the Paragard and the Mirena. I had them after each 3 of my pregnancies, Paragard, then Mirena. I loved the set it and forget it. I loved that I didn't have to worry about remembering a pill, because that's hard to do when you're up all night, and day and night have no meaning. And, you know, especially when you're breastfeeding, it has to be progesterone only pill, and you have to take that in a really short window. And unlike the combination birth control pill, which you might have been on in high school or college, when you're on the POP, the mini pill, if you miss it by a half an hour, you could get pregnant. There's no like missing it for 3 days and then just doubling up for the next 3 days. So
which I don't recommend anyway. Please don't plan on that.
You know, and so I knew for me, I did not want to get pregnant until I was ready. Even though it took me 3 years to get pregnant after I had Pierce, I was like, oh man, I need to make sure I got this one under control before I introduce another one. And so, and also for me, my periods are not debilitating. I don't have like endometriosis, but they're, you know, a week out of every month where I have diarrhea and cramping and wicked bad migraines, and I gotta like get shit done. So like, you know what, not having to deal with that is really life-changing for me. So just like keep it in mind, you know, be open-minded to it. Bad side effects can happen with any type of medication, but this, you know, what we call long-acting reversible contraception, LARC, things like IUDs, the Nexplanon, you know, these can be really excellent options for busy parents.
I completely agree. And also, random note about endometriosis. Mirena is actually shown to reduce patients' pain who have endometriosis, which is not originally what I was taught. I found this out as an attending outside of residency because I had a few patients who are on it, and I wondered if that was the best choice for them. And I looked into it more, and large studies that were done also by the infertility specialists who often help these patients deal with their pain, did find that most patients would improve using that rather than using a systemic hormone, which so many patients find unpleasant, especially after they've had babies.
Mm-hmm.
Hmm. Well, we talked about contraception and we talked about IUDs and we talked about getting pregnant, but let's talk about how you get pregnant. So what about postpartum sex? Like, what should people
Oh,
know? Like, I know sitting in the support group that I've led since 2007, the conversation often comes around to my partner wants to do it and I don't really want to. And I would
yeah.
estimate, I always, over the years, I would estimate just my own personal data collection of people I've spoken to who've just had a baby, that on average, most people don't want to have sex. Sorry, most people who've just had a baby don't want to have sex until around 4 to 6 months, not weeks, months. And their partner, I like to share that in prenatal classes just to give like
Yeah.
good expectations for partners because they're like, well, by 6 weeks, they should say yes. I'm like, just because you physically can does not mean that they want to.
Oh.
But why, what is it? Like, what changes? What's the research out there about lubrication, dryness, effects of
Mhm.
pregnancy on postpartum sex?
The first thing I will say is that it's highly variable. I have had some patients who voluntarily wanted to have sex at 3 weeks postpartum, which is
Yeah.
not recommended. And many other patients who have to wait. And I've unfortunately had a few who had ongoing issues that needed addressing because it prevented them from having a healthy, happy sex life, over 6 months after their delivery.
Right.
You're absolutely right. The vast majority of women, about 85%, will have at least one issue with postpartum sex. How severe that is and how much that affects the relationship is completely relationship dependent. But it is also true that by 3 to 4 months, most people are getting back in the groove of things, and it becomes a much more acceptable proposition for them. There's different reasons there, and all the reasons are highly variable. One of the biggest ones, especially for breastfeeding moms, is that the mucosa, which is the inside of the vagina, and the skin on the vulva change their texture and they become thinner. They become drier perceptibly to some women, and the way that your hormones work from your brain to including your breasts means there's a large amount of prolactin that gets released, and that's kind of where your dopamine is coming from, and the sex drive gets really, really, really suppressed because your estrogen, progesterone kind of go down. And so there's a lot of people who are just not interested in sex, and when they attempt it, they find discomfort physically. I will also say, as I'm sure that you guys have touched on at some other point, postpartum depression is a thing.
Right.
And
Mhm.
patients who are suffering from postpartum anxiety or depression, or even just the postpartum blues that are kind of lingering for a while, a lot of them are really not interested in sex. There's also quite a lot that changes with your body as far as stooling and voiding patterns go. And so there's a lot of women who will say that they leak when they cough, when they sneeze, or when they have sex. And there's some women who feel that they I'm trying to find the medical word for pass gas. When they pass gas, they feel I'm like
Flatus. It's
I was
flatus,
gonna
Kelly.
it's flatus, yes. I was gonna use what my mom calls it, which is fluff. When they fluff. But so sometimes the passage of gas becomes something that they can't necessarily anticipate or prevent, and so that can happen a little bit more abruptly. And there's a lot of women who are very self-conscious about that, and so additional pressure on their perineum can make that happen. Plus, there's some people who have healing tears, or who had damage to their cervix, which is thankfully not common. there's a whole bunch of reasons that people can find sex an uninteresting proposition after they've delivered. The major keys of advice that I give to people, because these are some of the few things that are conserved from person to person. Communication with your partner is key. And like you mentioned, Jeanette, if there's any possibility of letting your partner in on the secret ahead of time that your sex life is not necessarily going to be exactly the same immediately after delivery, but it might be in the future, depending on what your goals are, that's a good thing, because the more that someone knows ahead of time, I think the more that a partner can be very reasonable about it, and you don't have to be in that space where everybody feels pressured by everybody else. I think also lubrication is key. And I certainly do recommend that to every single one of my postpartum patients, with the caveat, of course, that I tell them that whenever they feel ready is the right time. And in general, for most patients, they will start to be feeling better about their sex life by 4 to 6 months after delivery. And if they're not, or they're continuing to have an ongoing and specific problem, I always encourage them to talk to their provider, because sex should not be agonizing. It should not be mentally taxing for you to engage in. It should be something that both you and your partner agree to, and you should be agreeing to the acts that you're going to do. It's very important to make sure that you and your partner are on the same page about family planning and about romantic planning.
I'm going to do some real talk here, because I love that
Please.
advice, Kelly. And
I love the way you say things, though, Kelly. It's like,
thank you.
Romantic planning.
Well, this might cause some blushing for our listeners, but this is a very common question, like you said, in breastfeeding support groups and new parents. Nobody wants to talk about it. Let's be real. If you grew up in America, you grew up in a country with puritanical roots that really shame you around your body, around self-stimulation, masturbation, lots of things, like you're talking passing gas during sex, like self-conscious bodies. Your body is changing. You're trying to figure out this new body, right? Your leaking breasts will sometimes let down milk or release milk when you orgasm. Like that can be very uncomfortable for some people, because they're thinking, well, my baby is nursing from these breasts, and now I'm having sex and my partner wants to touch them. And isn't that weird? And, we have not, most people in America, been brought up with like a real sex positive, like masturbation, self-exploration positive, leaking breast milk is okay during sex positive.
And some partners might like it.
Right.
Ask them.
But you know what I mean?
I dare say many will, unfortunate, but I would agree with you. I think that the women will probably find it more problematic than some of the partners.
We're shaming people for breastfeeding at Target, never mind leaking breast milk when they're having sex. So like, if you grew up in America, you're coming at this with some handicaps, okay? But let me be real with you. You got to think outside of the box. I've had 3 kids. I loved having sex and I love my husband, but I wasn't quite ready to have sex the way that I might have before I had a baby, right? Right away. But you know what? Sometimes maybe you watch some pornography and your partner masturbates and you help him do that. Maybe your partner does a sensual massage for you, and maybe there is some oral stimulation but not penetration. Maybe a vibrator is used to orgasm and then penetration happens, which makes you more lubricated, right? So I know that I'm making a lot of people blush right now, but the reality is that, and you know what, you also have to be creative about where you have sex. So I have had sex like God, I hope my kids don't grow up to watch this, but the other day we told my kids that we were going to give Dad a haircut, and we did give Dad a haircut, but we also had sex in the bathroom. So
you're not the first parents that have done that.
No, I'm definitely not.
In the laundry room.
Exactly. If you're a parent, you know what I'm talking about. You've had sex in the laundry room. You've had sex in the walk-in closet because your kid fell asleep in your bed. And so you have had to be creative about having sex. The joke between my husband and I, we used to live across the street from my parents. So if we'd be over there for dinner, I'd like look at my husband. I'd be like, hey, Mom and Dad, can you like watch the kids for like 15 minutes just so we can put some stuff in the attic? And that was our code word for that. We were actually going to go have sex. In the
do I need to message Paul and get his approval before I publish this?
Oh God, Paul and I have been together since we were 18 years old.
Yeah.
Okay, Paul knows that this is the kind of stuff I talk about. So what I'm saying is sometimes you got to put some stuff in the attic. And by attic, I mean, you know what I mean, right? So
Yeah.
you got to be creative. It's not going to be like the perfect time in bed on your own bed. No, it's sometimes going to be on the floor of the office because your kid is asleep in your bed.
I'm gonna
And you
love
know
it.
what? The kitchen and the pantry aren't terrible choices either.
Right.
Because there's coconut oil there, and coconut oil is actually a really great lubricant that is not bad for you, and is not gonna, especially for my postmenopausal patients, I recommend coconut oil, and they say, really? And I'm like, it melts at body temperature, baby.
And it does have nice.
And also, if it doesn't work out for you, you put it, and if it doesn't work out for you, you put it back on the shelf. It's fine.
I'm gonna love it in 10 years if we all of a sudden we're just listening to something and people go, I'm gonna go put some stuff in the attic, and then it like takes off as a code word across the nation.
Feel free to use it. Feel free to use it. Well, the joke was like we could never put anything in the attic because the kids would try to climb up the stairs, and so it was like the perfect excuse because my parents they never thought twice about it. They were like,
oh, okay, so they weren't in on the joke.
No. That definitely would kill the mood if my parents were in on the joke.
Yeah.
All right. One last question that I know if we're talking about embarrassing things, too many people are afraid to ask, but I know it's on your mind. Just like pooping when I push. Am I going to poop when I push?
Yep.
You know, that's a question people have in childbirth class. The question is, should I wax or shave my pubic hair before a pelvic exam? Or before I have a baby, I'll add, right? Should I wax or shave my pubic hair before I go in to have my baby, before I have my annual, exam? What do you think, Kelly?
Well, so, I mean, at first, and patients will say this to me almost every day. Oh, I'm sorry, I didn't shave. Oh, ignore the situation. Oh, I can't see what's going on down there. As if, first of all, that would pop into my mind first. So, I mean, at first blush, it's like a funny conversation, but you're absolutely right. It does, underlying that is some kind of idea that there's a standard and that you should look a certain way. I try to be as body positive as I can within the context of still putting forward health positive information. But I strongly feel, and I can't state this strongly enough, no provider of healthcare for your lady bits should ever make you feel any kind of way about your private pubic hair, etc. What you choose to do with it, how you choose to style it is completely up to you. You certainly do not need to excessively groom before you come in for an annual exam. Your provider should be able to work with whatever you've got going on. And the same goes with delivery. If you are more comfortable that way, fine. But there's a couple of pointers that I'd like to throw out there. When you're pregnant and postpartum, be careful with your skin. It's very fragile. And also, as all the patients like to jokingly mention, they often can't see what's where. So be especially careful with sharp objects next to body parts that you can't see. Bleaching anything is never recommended. Putting Nair or other depilatory creams on your pubic area is not recommended. I can't tell you how many times in residency I saw teens who thought that was the easiest way because they couldn't afford a wax, and that can lead to, it can lead to chemical burns. It can lead to breaks in the skin that are going to put you at risk of getting abscesses, a vulvar abscess, or a Bartholin's gland abscess, which is way worse than just having hair. When in doubt, if you like to keep things not super long, clip it. They have, clippers out there. I would not say use your husband's clipper. Probably don't do that. But get your own maybe. If you want to keep things not long.
It's a beard trimmer. Yeah.
Yeah, it's the size. Yeah, exactly. It's like a beard trimmer because that will keep you feeling a little more free from impingement. But
I know people are wondering why you just said we
off.
can't. So why can't we use our husbands? What is the issue? Someone's going to be thinking that. So let's just answer it because I thought of it.
I have a great answer for that. Herpes.
Oh.
Don't do it.
Okay, interesting.
Cold sores, 90% of the population is been exposed to one and gets cold sores at some point in their life. HSV1 can now go to your vulva and vagina, and like I said, breaks in the skin. You don't see them, you don't feel them, but they're there. And then you're going to need to have a really awful herpes conversation with your doctor and your partner, and there'll be lots of crying. Don't do it.
Don't do it. I agree.
Do
You know,
it.
it's funny because people are very concerned about this, that like we are going to judge them if they have pubic hair. And I just want to remind everybody that if you have a baby in your belly, that means you went through at least a female puberty, and you grew pubic hair if you are a human that went through a female puberty. And so humans have hair. And you can remove that hair if that's the way you like to style your body. You can remove the hair on your face or your head or your vagina, but you also can just leave it or trim it or not, because we know humans have hair. Humans have hair on their legs. We don't expect pregnant women 40 weeks pregnant to shave their legs. The number of times I've heard, oh, I had to get my partner to shave my vulva. I had to get my partner to shave my legs. I'm like, I hope they did a good job. I'm like, you went above and beyond. You did not have to do that. We all know that you have hair.
You can also tattoo it and pierce it if you want to.
Oh my gosh.
Oh my gosh. Thank you so much, Kelly, for coming on the show. This
Absolutely.
was so awesome. So
many more
fun.
topics
I
to
miss
talk
you
about
terribly.
too. Will you come back? Will you come
I know,
back?
we've got to have you on
Gladly. Glad we should probably cover some STD myths too, because you know, if you haven't already, herpes. We got a lot to talk about, y'all.
I would love an update on that. Yep.
Yeah, it's not as scary as you think, you guys. Idea. It's okay.
Okay.
Awesome. Yes.
All right, let's do it. So thank you so much for coming on our show. We appreciate your time and expertise. This was just great.
And we hope you all have enjoyed today's show. And we hope you'll tune in again. Babies in Common is a community for you. Remember, we all have babies in common.
Babies in common.